Systemic arteritis has been classified in several ways. This is one of the classifications. Type 1 is the pulseless syndrome, which means that the person may have no radial pulses, and there may be no carotid arterial pulses as well. This is called the Takayasu Shimizu Sano type. Takayasu was a Japanese ophthalmologist that described the ocular changes in some Japanese patients due to ischemia to the retina, and these patients also exhibited evidence of decreased carotid pulsations and absence of radial pulses. The pulses syndrome involves the ascending aorta, the arch, and the brachiocephalic arteries. The second type is the atypical coarctation involvement of the descending aorta, and it's called the Ueno-Kimoto type. The third is the thoraco-abdominal form, which involves the arch of the aorta and its branches, as well as the abdominal aorta, and it's the most common, seen in 2/3 of patients reported. Finally, we may have a combination of pulmonary arterial stenosis with systemic arterial There are several guidelines for the clinical diagnosis of Takayasu arteritis, or so-called systemic vasculitis. Signs and symptoms include symptoms of cerebral ischemia, such as vertigo, especially while looking upward, fainting spells, visual disturbance, especially in direct sunshine. Symptoms of extremity ischemia, such as cold fingers, and easy fatigability of the upper extremities. Symptoms of aortic or renal artery stenosis, such as headache, vertigo, and dyspnea. Possible slight fever at the onset of the disorder. Other clinical findings include abnormal pulses in the upper extremities, weak or diminished radial pulse, right versus left difference in the radial pulses. So, in other words, the radial pulses should be obtained simultaneously, and in order to determine if there is any flow retardation in one extremity. Then we have other findings such as abnormal pulse in the lower extremities, be that the accentuated pulses or diminished pulses. Other findings are vascular murmurs listened or obtained in the arteries of the neck, in the back, or in the abdomen. There are a number of ophthalmological abnormalities that usually reflect ischemia to the retina. A number of laboratory findings have been described, such as elevated SED rate, the positive C-reactive protein test, the increased serum gamma globulin levels, and the important diagnostic points are the prevalence of this process in young women. We see a lot of these cases in Japan and in China. The final diagnosis of the disease is made by observing the presence of an arteritis on histological section. We can use CT and MRI to diagnose the vascular problems, and certainly angiography is virtually pathognomonic of this diagnosis. Differential diagnosis includes other vasculitides, particularly thromboangiitis obliterans or Buerger's disease, arteriosclerosis, collagen vascular disorders, and some congenital vascular abnormalities. Here we see histological findings in Takayasu arteritis. This patient had occlusion of many systemic arteries of the arch of the aorta, and note the giant cells and round cells infiltrating the wall of the artery, which appears markedly disrupted. This is This is an arch aortogram of a Japanese-born woman cardiologist at the University of Miami, which shows supravalvular aortic stenosis, a focal narrowing at the level of the aortic isthmus. Note that there is a narrowing of the proximal left coronary artery. The arteries that take off from the arch of the aorta also were involved, like the proximal innominate artery with slight poststenotic dilatation, and there was a severe narrowing of the left common carotid and left subclavian arteries. There was also narrowing of the mid-descending aorta, as seen in the picture to your right. Another case of Takayasu arteritis showing multiple arterial narrowings in brachiocephalic arteries. Here we can see an arch aortogram showing narrowing of brachiocephalic artery. This is an MR angiogram of a patient with Takayasu arteritis. In this particular case, there was arteriosclerotic dilation of the ascending aorta and prominent collateral arteries observed ventral to the descending aorta. Occlusion of the left common carotid and left subclavian arteries was also present. This is another case of systemic arteritis. One can see a thrombus in the anterior wall of the ascending aorta and diffuse dilation of the thoracic aorta with marked thickening of its wall. The irregular lumen diameter is due to the atherosclerotic changes that are usually superimposed to the inflammatory process. A thrombus occurred also in the proximal descending aorta, as seen to your right. A child with systemic arteritis, note areas of narrowing of the proximal abdominal aorta and indirect signs of occlusion of the celiac trunk as manifested by enlarged right subcostal arteries that connect with the right hepatic artery. There was also narrowing of the splenic artery and of the renal. A lateral abdominal aortogram shows narrowing of the mid-abdominal aorta, narrowing at the takeoff of the superior mesenteric artery, and this patient also had occlusion of the inferior mesenteric artery and marked the stenosis of the celiac trunk. An abdominal aortogram to your left and a CT angiogram to your right, where we can see in both concentric narrowing of the proximal renal artery, and this patient had another case of proven systemic arteritis. This is a young woman who came from the Bahamas with headaches and ocular changes. The frontal chest rentgenogram showed enlargement of the heart and some widening of the mediastinum. Note that there is oligemia of the upper lobes. This patient was thought to have systemic arterial hypertension and in addition pulmonary thromboembolism. On physical examination, the radial pulses were absent, as well as the femoral arterial pulses. She was catheterized and only through the catheter one could establish the presence of systemic arterial hypertension. The lateral chest rentgenogram showed a prominent ascending aorta. A pulmonary angiogram showed oligemic upper lobes, but no filling defects characteristic of pulmonary thromboembolism were observed. And we can see abrupt termination of a right upper lobe pulmonary artery, but no filling defects could be seen. The venous face of the pulmonary artery injection shows again the oligemic upper lobes, and we see normal appearing veins from the lower zones and a normal left atrium. A late phase of the pulmonary artery injection shows the thoracic aorta, which appears enlarged, and marginal irregularities are related usually to arteriosclerotic changes that are secondary to the inflammation of the aortic wall. Similar findings can be seen with giant cell aortitis and with luetic aortitis. Note also the occlusion of the left carotid and the left subclavian arteries at their origin. Axial MR study of the neck shows thickened carotid arteries. This is an MR examination of a patient with systemic arteritis. One can see the marked thickening of the wall of the aorta, which also shows a